finally to our last speaker, Mark Jennings, who's the Chief Solutions and Services Officer at Strasis. And Mark will discuss how to unlock trapped value whilst delivering what patients truly need and how resources can be allocated efficiently. There's been a number of questions in the Q&A around this area, Mark, so you may be preempting the Q&A session with your presentation. So over to you.
Well, thank you, Mike. Let's hope so. And good afternoon, everybody. And thank you, Patty, for that wonderful section beforehand as well. So if you can move on, please, Carl, we'll get straight into it. I'm conscious of time. I wanted to try and explain how medicine had become increasingly complicated, scientific, specialised over the last few years. But I thought, Patty, actually, you did a great job of that. If Dr. Garfield was talking about dramatic advances in medicine in 1970, you wonder what he'd think looking at where we're at today in terms of the advances in medicine. And you went back to 1933 at the start, and being British, obviously I can go back a bit further. So I thought I'd start in 1518. Now, I did originally want to have the General Medical Council's list of 65 medical specialities that they currently recognise, plus the 31 subspecialities they recognise, but I've not been able to find dates of when they were officially recognised. So I've resorted to Royal Colleges. And what you can see here is just sort of the start of Royal Colleges in England over the 517 years or whatever it is since 1518. And, you know, the kind of point here is that the NHS actually was formed between the 4th and 5th. So between the Royal College of Radiologists and the Royal College of GPs, the NHS started. It was never properly planned. You know, it was a nationalisation of various charitable hospitals and private hospitals brought together. But since then, there has been dramatic increase in medical knowledge and specialisation. In fact, we can quantify that in Royal Colleges and say 10 out of 14 Royal Colleges have formed since then. So therefore, healthcare is at least 71% more complicated now than it was at the start of the NHS. That obviously has consequences. So Carl, if you move on to the next slide, please. Our good friend and colleague Samir Gray talks about the 20th century as being the century of the hospital and the 21st century of the system. You know, because of that complexity, there was a point in sort of the 50s, 60s where you could actually have a local hospital for, say, 100,000 people delivering most of, if not all, the secondary care that that population needed. As we have got to a state of complexity in both need and in provision, that is no longer the case. You have to look to the system. You know, the conditions now are fundamentally different. The modal age of death back at the founding of the NHS was 0, right? You were most likely to die in your first year of life. Now that modal age of death is 87. We're in a totally different place, and one size does not fit all. You have to think about the different types of care that are needed per 1,000 people in the population, per 10,000, 100,000, million, 10 million, etc. Right? For every order of magnitude, we need to think about a different level of care and different care needs. And that's why you have to be thinking about the system as an entity. And it's about balancing the provision of care for the patient against the efficient use of capital and finances in that care model. So if you could move on, please, Carl. So we talk about the concept of trapped value within the system. So you have this complicated system. We kind of have this balance between a relatively old organizational system and a whole lot of new challenges, new demand. And there's two main types of trapped value that we see within that. The first, on the right-hand side there, we should always start with the patient, and it is the complexities for the patient. So the patient now essentially has to navigate that system. It used to be more straightforward, where the GP would essentially navigate for the patient through into secondary care. But in many cases now, there are routes around the GP, or the GP is a route into secondary care. But then once in secondary care, you effectively bounce between specialities. If you take somebody with shortness of breath, for example, is it toxicology? Is it lungs? Is it heart? Right? You can go around lots of different aspects of that care system, trying to find both the diagnosis and the right treatment. So there is missing, if you like, opportunities both for improved health outcomes and for efficiency in how that individual has to navigate the system currently. On the other side, there's all sorts of trapped value around the organisations themselves. So there are challenges in terms of the diseconomies, as we would call it, of scale, learning and scope. And we'll talk about those a little bit more. So if you could move on, please, Carl. So when we talk about economies of scale, we're basically saying, as I'm sure most of you understand, that if you do more of something, the marginal cost to do that should decrease. We talk about economies of learning. What we're saying is, as you do more of something, you should get better at doing it. Your consistency should improve. Therefore, your predictability and quality should improve with repeated tasks. And then finally, in terms of economies of scope, how you think about the range of things that you do. There is an element to which the more things an organization does, the more they're able to share certain fixed overhead costs across diverse product lines or services in healthcare, and therefore deliver some benefit to the population relative to the outcomes that they achieve. But that is never a straight line. There comes a point where actually you start to have organizations that are too complicated. And at that point of complication, things start to unravel. So if you could move on, please, Carl. So what we're seeing at the moment is in economies of scale, yes, they tend to happen within healthcare. If you see larger trusts with more patients, will typically deliver services more efficient than smaller trusts. What we don't see is those economies of scale being shared within a given system. So within an integrated care system, for example, you might have great differences in terms of how efficient individual trusts are at doing certain actions. We also know that capital intensity in healthcare is increasing dramatically. I mean, if you walk into a modern operating theatre, they are huge, they are full of kit, they have very complicated airflow with different airflow zones, etc. There is a complexity and a capital intensity there that means we really have to think about efficiency. In terms of economies of learning, what we're seeing is a lot of fragmentation of skill. So the more rare conditions that are uncovered, almost the less reps, surgeons and doctors can get in terms of diagnosing and treating those conditions. So you have to think about concentrating care more, the more that we are looking at that fragmentation of skill, that fragmentation of specialism. You need people to see enough cases to be able to handle them well and to have built up experience. And then finally, in economies of scope, the idea that an organization can do everything or most things for most people is rapidly being disproved. You have to have focus in the management team, in the board. They have to make decisions and decide exactly what their purpose is. So if you could move on, please, Carl. When we're talking about how you make systems work, therefore, there are three keys that we have here. So three key elements. The first is thinking about the organizing principle. At the moment, the NHS is essentially geared around the organisation, the trust, in some cases the site, in some cases, you can look beyond the trust to say, okay, there are provider collaboratives and so forth, but it is organised around the organisation. That has to change to being the patient. Patty talked about segmentation and looking at models of care, and that was recognised by Kaiser Permanente, 30 plus, 40 plus, 50 plus years ago. We have to bring that into the NHS. Second point is around that choice on what the organisation does, which is about strategic choices and being very clear on those. And the third, you have to have an ability to measure value. We've heard about the triple aim, the quadruple aim, etc. You have to be able to measure value on a broad spectrum that takes in account all of those different aspects of value. So if you just move on, please, Carl. What that means is actually on that first point, the organisation, we have to orient around the patient. At Stratis, we look at these 12 segments as our primary segments for looking at all healthcare. 2 of those are healthy, so 10 of those relate to those who are generally consuming health services as a whole. But once you start to think about how you optimize the system for a given group here, you look at it in a completely different light. And if you were allocating resources, you would allocate those resources differently as well. So if I take one example that's maybe sort of not one of the more obvious, if you take living with it, that is people who have long-term conditions but are largely able to self-manage. How do you help those people continue to self-manage as well as possible for as long as possible? Whole systems should be geared around that rather than necessarily around an ology or around a building, right? It's about how do you help those people live the best life they can with what they have to deal with. If you move on, please, Carl. The next point then is around strategic choice. And really in healthcare organizations, there are 3. Do you optimize for volume and consistency, which is really sort of the old DGH model, but saying actually there are certain treatments within there that should be looked at as relatively transactional, as high volume, as how efficiently, how well, how kind of, with unwarranted variation, absolutely limited in this process, can we drive those out? The next area you could choose to specialize in is around tertiary, quaternary care, but product excellence. The best research and development, hiring talent to really push the boundaries of medical science in certain areas. And the third option is looking at networks and patient advocacy. So how do you join the whole system together as it naturally gets more dispersed on behalf of the patient, and how do you integrate services around the patient? Those are the choices that organisations face today. Can move on, please, Carl. The final thing you need then is this ability to measure value. So this is why we have the concept of what we call the Strauss's value index. Here we're looking at per inflation adjusted unit of spend, and we use £1,000 of spend in this context. How much value can an organisation deliver? And that value that they're delivering is measured in terms of the work that they're doing, but that work adjusted for the quality of their clinical outcomes, the quality of the customer service that they're doing, and the starting health of the served population. You have to look at those as well as the inequality that the patient population faces to determine, to the point around, what is good money, what is good spend in healthcare, and how do I better allocate resources. You have to understand all of these elements and put those into a single metric. Now, we're interested here less in the individual points than in the slope of the line. Are organisations trending better, worse, or flat over time? But it's important to think about all of those elements in terms of how you assess whether you are making the right decisions for your population and whether you're actually optimising in the way that we've discussed so far. So, conscious of time, I will end there and hand back to Mike.